Hello? 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 Good evening, sir.
Good evening. Good evening. Thank
I'm
you.
audible? Am I audible, sir?
Yes. Yes, please.
I just thought I'll just check my sharing of slides.
Yes. Yeah, please.
Thank you, sir.
Good evening, Dr. Varghese.
Good evening. Nice to
Thank you. Thank you for joining.
see you here.
Thank you.
Yesterday I could not participate, but today I'm here much early.
You could have, you should have messaged me. I was all the time on my phone. I'm so sorry. I'm so sorry.
I subsequently thought I would watch the recorded version also. I won't miss the chance.
Yeah. Everything will be posted by Dr. Avinash team on the YouTube channel. So all the presentations will be there. Yes.
So the format is like any talk. I will introduce the speaker, introduce the subject, and invite him to talk. And the talk is for how many minutes?
15 minutes. I'll keep a watch on the time.
15 minutes, and then we have a question and answer session.
Yeah, question answer, and then in the end,
immediately after the talk. Yeah, that's
have
for how many minutes?
So total each session is 30 minutes.
Okay, initial 5, then 15 minutes talk, that's 20, and QA is 10 minutes. Okay, we start at 7 and close at 7:30. Okay, perfect.
Good evening, Sadiq.
Hello, sir. Good evening. How are you?
I'm fine. Good. Good evening, Arun.
एक बार check कर लें क्या?
हाँ, बिल्कुल. Yes.
Good evening, Dr. Sadiq.
Hello, Dr. Varghese. How are you?
I am fine. We are meeting after such a long time.
I know.
Yeah, I think we have met when you were in Kerala long back.
I know. Hi, Arun.
Good evening, sir.
Good evening. What, you lost weight and all? Huh?
Yeah.
Going for the film role or something like that? Arun?
I think he got disconnected.
Sir, I didn't hear you.
No, I'm saying, are you getting into films or something? You're looking smart.
Sir, done some touch up and all that. Seriously, lots of gray hair.
Yeah, it's required these days.
Sir.
Can I just share?
Yeah, please share. Yes.
So. Not coming, huh?
Yeah, it just says started screen sharing, but we don't see anything. Now I think we see. Yes. Good.
Okay.
Good.
Be fine.
Don't see Rupjyoti still. Are you in? Okay, that's fine.
So, Deepak and all are going to join?
Yes, Deepak just called me. He will join at 8:30 because he is a part of the open house. So he said he'll join at that time only. Yogesh was there yesterday. Yogesh was there. Yogesh is now in Saudi.
He's moved?
Yes.
He's moved for good?
I'm not sure, but yeah, he's taken a job there. So his family is still in Germany, but he's in Saudi.
Okay. Hey, Puneet.
Hi.
How are you?
Yes, sir. All
आज
fine.
आप करिए, आज आप moderate करिए. I'll just.
Hi, Puneet. How are you?
Hi, Varghese. How are you?
I'm great. Yeah, we are seeing after quite some time, no?
Yes.
After you left Amrita.
Your hair looks like a cap that you have worn.
Is it?
No, I was wearing a cap till now. Just took it off, so I guess.
If we want to see Puneet more often, we have to become a bird.
Means he will see us more often then.
We will also see.
If we become birds.
We have about 4 minutes to go. We'll start at 7. Dr. Rupjyoti is logging in. So let's see log in.
Hello, sir.
Yeah, you want to just share your screen because anyway you are first speaker. So
Yeah. Okay, so
yes.
Yeah. So I'll just yes. What is it visible, sir?
Yes.
Yeah, okay. The time is 15 minutes, right, sir?
Yeah, 15 minutes for you, then 10 minutes audience question answer, and 5 minutes for the chair.
Okay. Okay.
Yes, Anand. Hello.
Good evening, Dr. RupjyotiTalukdar. I am Dr. Varghese.
Hi. Hi. You.
So it's 7 o'clock. I think we'll start. Good
Yes,
evening,
sir.
everyone. We welcome all of you to the second day of the third masterclass on chronic pancreatitis. These masterclasses are being organized by Jaipur Surgical Tutorial, which is an online education portal that we started at the Mahatma Gandhi Medical College and Hospital about 2.5 years ago when I moved from CPGI Lucknow to Jaipur. And all these activities are being coordinated by my young faculty colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery with me. He's been conducting and organizing all these activities. So we conduct a session every day, 9 to 10 Indian time, where students present cases. Sometimes they present an operative surgery session. And very occasionally we have a faculty lecture or an open house session. And anybody can join the Jaipur Surgical Tutorial for free. In between, I will be projecting a slide which will give the WhatsApp number of Dr. Anand Nagar. You just have to send him a message and he will add you onto the group, and then you will receive all the information about all the sessions of Jaipur Surgical Tutorial. So with that brief introduction about JST, I would hand over to Dr. Thomas Varghese, who's at the Malabar Medical College in Calicut, to chair this session. And the speaker is Dr. RupjyotiTalukdar, who's the Chief of Pancreatology at Asian Institute of Gastroenterology in Hyderabad. Over to you, Dr. Varghese.
Thank you, Professor P.K. Kapoor. At the outset, let me thank Professor Kapoor for having invited me to chair this session. It's a great session, and it's an online opportunity not only for the faculty but also for the students all over India and all over the world to learn more about pancreatic disease and other surgical disease as well. Today we have an interesting topic: how is our chronic pancreatitis different from that seen in the West? And the speaker for today's session is Dr. RupjyotiTalukdar. He is from the Asian Institute of Gastroenterology, Hyderabad. So after his initial studies from Guwahati, Assam, he went to USA, where he did his postdoctoral studies and GA fellowship from University of Minnesota and subsequently from Mayo Clinic. He's a person who is very much interested in pancreatic disease, that is perhaps the only clinical pancreatologist in the country where he devotes his entire time for the study of pancreas. There's a lot of interest in the various types of acute pancreatitis, different types of chronic pancreatitis, its management, its genetics, the microbiota, and of course, in basic research like stellate cells in isolation of stellate cells and its importance in pancreatic disease. And he has lots of publications, and he is the reviewer of around 20 international journals. So you have the best person to discuss this topic, and without much delay, I would invite Dr. RupjyotiTalukdar to deliver his presentation. Over to you, Dr. Talukdar.
Sure. A very good afternoon, very good evening, and let me thank Dr. Varghese for the kind introduction. And of course, I can't go without thanking Dr. Kapoor for this kind invitation and opportunity. So a very interesting topic has been assigned to me today. How is our CP different from that seen in the West, or is it really different? That might have lots of therapeutic implication, mechanistic implication, and as we go on through the talk, we'll learn more about it. So let me begin. With the story of a disease that has been there since several decades, that is still spoken about in the West, even in India. It's written in the books. There are book chapters, articles, but many of the younger colleagues or the new age physicians have probably not seen that. And there is an implication why I begin the story with this today. So what happened way back in 1955, 1959, disease entity from Indonesia was reported by someone called Zuidema, where the disease was like young, and the same phenotype was actually evaluated in great detail by Dr. Varghese in 1962, and he published the data which made this entity globally recognized, and that was called the tropical chronic pancreatitis or tropical calcific pancreatitis. Lots of nomenclatures were given during that time, but eventually the TCP or the tropical chronic pancreatitis stuck on. And the specific characteristics of this disease was the patient had very severe pain during childhood, diabetes in adolescence, and death in the prime of life. So these are the trio or the triad of the classical disease called tropical chronic pancreatitis. So initially it was thought that it's probably localized or seen in the tropical region of the Eastern world, but then eventually papers came out later in 60, 63 and 76 from African and countries from South America. And then it appears that it's more of a disease related to the tropics. And then this is, I would call a landmark study by Professor Tandon, my mentor, who had systematically evaluated this study with his DM student, Dr. Balaji in Kulon district. And what they did was they went to the village in the Kulon district, and more than 6,070 families they screened, nearly 30,000 individuals. Out of that, 36 patients were found to have chronic pancreatitis, which was confirmed later on by bringing them back to the hospital and doing other further tests. And so this brought up the incidence of chronic pancreatitis or prevalence of chronic pancreatitis in India as 126 per 100,000. This is a very commonly quoted number even now, but I think now this number has changed because this study was done only in a limited population. But if we talk about a pan-India population, these numbers will most likely come down. But nevertheless, this is much higher than what we see in the West. So this is one of the difference. The prevalence of chronic pancreatitis in India is much higher than we see in the West. And if we see the characteristics of this disease, it was drastically different from alcoholic chronic pancreatitis, which was seen in India and even in the West. The patient's socioeconomic status were usually poor. Almost all of them had diabetes at some point in the disease course. It was a very aggressive, accelerated course compared to alcoholic chronic pancreatitis, which was much slower. There were big chunks of calculi in the large ducts. Almost all the patients had calculi. There was marked ductal dilatation and significant gland fibrosis. So this made this disease very unique and different from alcoholic chronic pancreatitis. Several factors, etiological factors, had been ascribed, like cassava, which is tapioca, which used to be the staple food of many of these people in this endemic region, not only in Kerala, but all regions in the tropical belt. Malnutrition was supposed to be one of the etiology. Familial, because there was 8% patients with clustering of this disease, and few genes like reg1 alpha, reg1 beta were ascribed. But eventually, over the years, several studies have actually disproved these. So these were not really specific to this disease, and even people who are not having these risk factors had similar type of chronic pancreatitis. So what happens? This is very interesting. When the days passed, and Dr. Balakrishnan is one of the doyens in pancreatology in India and the world, and he has published seminal papers, and he and his group actually followed this patient of the same biological behavior over a decade. So what came out in 2004 was when they evaluated the same group of patients from the same population, same kind of risk factors. What came out was that the mean age of the patients in 2004, same biological behavior, idiopathic or tropical pancreatitis, age was 30 years compared to 20 years in 1984. The BMI improved, meaning the patient's nutritional status improved. The socioeconomic status was also better in these patients, and diabetes was markedly less compared to what was seen in 1984. So what does that mean? That there has been a change in the biology of the disease, or are these diseases really tropical chronic pancreatitis, or has there been a change in the disease? So now let's come to the recent modern era. What kind of disease do we see now? So this is data from the Pancreas Clinic at AIG, almost 900 patients from two time periods, 2012 and 2019. And this is the distribution of patients that were included in this study from all over India. Majority was from the south and the east. And what we see here is, if we see again, the patients from south excluding Kerala, this is a different set from Kerala 2006 data. Then Eastern India, Northeastern region, and the other part of South India. If we see the mean age of onset now is almost similar. In fact, in Kerala, it's a bit later than the other parts of India. BMI is similar. They are not malnourished. Socioeconomic status, all of them are from the middle socioeconomic status compared to the lower socioeconomic status in the tropical calcific pancreatitis. Prevalence of diabetes was similar, with a higher incidence in Kerala in 2006. And the mean disease duration between the symptom of onset and diabetes were also similar. And the morphology of the disease was similar. So now it appears that we are dealing with the same kind of disease all over the country. And they are not following, or they are not showing up the typical morphology of what used to be called as tropical chronic pancreatitis. So there has been a change in the disease behavior. The TCP was supposed to be a disease of the young, very, very young onset disease. But so when we compared the disease behavior between patients below 30 years and above 30 years, again, we don't see any significant differences between the biological behavior and the demography of the disease. So similar proportion of patients had weight loss, and BMI was similar in both the groups. Diabetes, of course, was more in the patients with over 30 years that could have other etiological factors. Also, some of them may be having type 2 diabetes, or because of the duration of the disease, probably they have more of diabetes. Dilated, again, morphological changes were similar in the form of dilated main pancreatic duct and presence of MPD stone. So again, we see a similar kind of disease between patients who are below 30 years, who has onset below 30 years, and who had onset above 30 years. So now what we see, what we have now, we earlier saw a disease, very severe form of chronic pancreatitis, early onset brittle diabetes, early death, localized to the tropics. Now we see a disease which is much milder compared to the TCP that we saw earlier. Onset is delayed by a decade. The diabetes is controllable by OHAs, and all of them are not brittle. Longevity increased, and they are not localized to the tropics. So what's going on here? So all these years, like last 10, 20 years, 3-4 decades, many things have happened. Many good things like better education, improving the socioeconomic status, better standard of living, better hygiene. These things have developed, new gene discovery. So that has improved the early diagnosis of the disease, and also probably have changed the biological behavior of the disease because of the nutritional status changes. But at the same time, several ugly things started happening, like increase in alcohol consumption, smoking, industrialization, exposure to processed food toxins. So all these could also contribute to the disease biology. So probably what we had seen, the disease natural history has been same, and the same natural history is seen in patients from the West also. So it is likely that what we used to call tropical chronic pancreatitis patients were seen at the end of the spectrum because of the lack of advanced infrastructure in diagnostics, and people not exposed to healthcare facility, or people not going for healthcare facility. But now the pendulum has swung towards a more milder side, and therefore we probably get the disease that we see, and which we can aptly call as the early onset idiopathic chronic pancreatitis. And this is what the Western literature also describes as two types of chronic pancreatitis, early onset and late onset. And this fits into the early onset variety of idiopathic chronic pancreatitis that is seen in the West. And that could be shaped up by complex gene and gene environment interaction. And then if we look at today's studies, and there was another pan-India study by Dr. Balakrishnan with more than 1,000 patients. So the typical morphology of tropical chronic pancreatitis of the dense calcification, early mortality, early diabetes is only in around 3.8 to 6% of patients today. So this could probably represent the far end of the spectrum of idiopathic chronic pancreatitis rather than a specific disease entity. So now is a difference. So we have seen already that few of the things are actually different between the East and the West. The age of onset is still lower in our patients. The disease morphology appears to be more severe with bigger stones, more dilated duct, more morphological changes. So this was an interesting study that was published last year, which looked at the, it's a kind of a systematic review, which looked at the differences in the chronic pancreatitis behavior or biology between the East and the West. And they looked at USA, Japan, China, South Korea, India, and so they picked up the published studies, and what they collectively reported was, they said that the disease was kind of consistent. The disease behavior was kind of consistent globally. It was mostly prevalent in middle-aged patients, 40 to 62 years, with an exception in India where still they are calling this TCP, which I don't think is correct. The onset is young. The prevalence of alcohol-related CP is higher in the industrialized nation based on the older studies. In France, for example, earlier studies have shown almost more than 80% of prevalence. In Korea, 64, 68. But the more recent studies from Japan, Italy, US, and Hungary has actually reported the incidence of alcoholic chronic pancreatitis to be much lower. And what used to be earlier discussed or described as alcoholic pancreatitis was not probably alcoholic pancreatitis in the true sense, because there are many other genetic elements associated with that. Malabsorption and diabetes are similar from the India and the Eastern countries with the West, but what the study reported is more in the West compared to the East, and opioid use, endotherapy, and surgery more in the West. So I think this is a good data, but I still have some reservations in some, because here in the West, even when you look at the East, China or Japan, South Korea, there are more industrialized than the Indian subcontinent. So there could be other factors, and I think it's important to look at the biology for the Indian subcontinent alone and compared to the others, and also from the other Asian countries like Sri Lanka, Bangladesh, Nepal, which do have a significant proportion. So what we did was, based on this
2 more minutes, Dr.
we
2 minutes, please.
Okay, so how many? Two minutes? Okay, I'll be fast. So based on that premise, we had actually started this study called the CIP-CSL chronic pancreatitis in Southeast and South Asia, where we are evaluating the demography, risk factors, and disease behavior from all these countries. And so far, we have recruited 1,500 patients, and where we will be individually analyzing the data from each country and then compare it with the West. So this is just a preliminary interim analysis. I'll not go through this because this is very rough data which have not completed the analysis. But the important thing in India are two variants which may have some clinical significance all over the globe, but there are global disparity. And if we see here, the PRSS1 gene, especially the N29I and PRSS1 R122H, these are the two most important genes that are associated with hereditary pancreatitis, which is a 50-fold increased risk of pancreatic cancer. This is common in the West, but fortunately, we do not find these two particular genes in India. We have done several thousands of genetic testing AIMS had done and CCMB had done, but this is the first case report that we could publish which showed a heterozygous phenotype of this. So it's good that we do not have the risk factor for genetic risk factor for pancreatic cancer on the background of chronic pancreatitis. So that is one factor. And the second is cathepsin B, which we find in India, but it's not seen in the West. In all our studies, it's consistently present and it's associated with chronic pancreatitis, recurrent acute pancreatitis, and we have actually shown that presence of the cathepsin B, this particular polymorphism. So this is something that is not seen in the West, and probably cathepsin B is responsible for the lysosomal hydrolase and activation of the trypsinogen. So probably it could have some therapeutic implications in the future. So this is an important difference between the India and the West. And then the other last two slides, other important difference is the response to therapy. So yesterday, Dr. Matthew Philip had talked about this study, the antioxidants that came from Pramod Garg's group several years back, which showed the beneficial effect of antioxidants in these patients. And we had later on again published a combination of antioxidant and pregabalin, which again showed benefit. So why this benefit happens is because in chronic pancreatitis, there will be loss of exocytosis, and there will be minor inflammatory changes within the acinar cells, and that happens because of the interruption or disruption of the methionine cycle or the transsulfuration cycle. So this is the logic of providing antioxidants, and we could show that methionine containing antioxidant, methionine is a donor for this cycle and it restores the cycle, that have a high odds ratio in favor of pain reduction. But then this study from Siriwardena, the Anticipate trial published again 10 years back, did not show any benefit in this patient. So, and unfortunately, most of the Western practitioners follow this study. They do not have much belief on antioxidant. But if we dissect out these two studies by Pramod Garg's group and this one, the Anticipate trial patients were older, they were alcoholics, majority of them were smokers, and they had high dose of narcotics. But if we see the Indian study, these patients which showed a benefit, these patients were young, non-alcoholic, non-smoker, and non-narcotic. So they were not given any high potency narcotics. So this is an important lesson. So actually this study tells us which patients will benefit with antioxidant therapy. And it's important that patients with chronic pancreatitis we should avoid high potency narcotics as much as possible. The West has burned their fingers with this narcotic epidemic, and they are trying to correct themselves by reducing the use of this high potency narcotics like fentanyl and morphine-derived nalbuphine. But this is starting in India. That is my concern. We now see lots of prescriptions of nalbuphine in these patients and things like fentanyl. So as long as it is not mandatory, this should be avoided. And this is very important message for the youngsters, the young clinicians who have just started their career. Because if you see these patients, these high potency narcotics have a tendency to cause degranulation of the mast cells, and that in fact increases the inflammation in these patients in the long run. So I think I'll stop here, and in a hurry I could not make a thank you slides, but I think I'll stop here and we'll start the discussion. Thank you very much.
Thank you, Dr. Talukdar, for that wonderful presentation. And the session is now open for discussion. I request participants to put your questions in the chat box so that we'll be able to interact with you. Now, to keep the ball rolling, I would like to ask Dr. Talukdar. See, in India, earlier we used to see the chronic pancreatitis described by Dr. Varghese. Then as Professor Balakrishnan said, now we are finding a change. That means we are finding these people in the third or fourth decade with the less of diabetes, no malnutrition, etc., etc. There is another issue. We were detecting them as chronic pancreatitis, but now we are seeing youngsters with the recurrent acute pancreatitis, and with the availability of US, we are able to say that actually these are chronic pancreatitis, not acute pancreatitis. And the study from All India Institute also alluded to that recurrent acute pancreatitis in India in youngsters actually evolve into chronic pancreatitis. Do you find a similar pattern in the Western studies?
In the West, firstly, the most common risk factor is alcohol, and yes, they do find. That's why now the dynamics of alcoholic chronic pancreatitis is also changing. David Whitcomb has been speaking about this. Even alcoholics are actually genetic pancreatitis. Alcohol is just a trigger factor. So now, even now, in like in the West also, the pendulum is shifting towards a more early onset. And when they do EUS, they do find changes, subtle changes of early chronic pancreatitis, even in the alcoholics, and of course, idiopathic is already there. So the dynamics has been changing in the West also, especially if we talk about alcohol-related chronic pancreatitis.
Are you aware of any studies done in India or elsewhere on recurrent acute pancreatitis and its genetics? Because if we understand the genetics, perhaps we may be able to intervene or at least predict the nature of the disease.
Yeah. So actually, we have conducted a study. We have a data of like more than 750 patients. We are soon going to publish it. We are doing the analysis. What we find is, if there is a combination of gene, for example, SPINK is very common in India, but SPINK by itself is not a disease causal gene. It's a disease modifier. There has to be another risk factor, be it genetics, be it other factors like hypertriglyceridemia, calcium, pancreatitism, that will trigger the disease. What we see is if the SPINK1 gene and the cathepsin B genes are having a homozygous or one homozygous, one heterozygous, those patients are likely to have a disease at a much earlier age during childhood, and they are having many recurrent episodes of pancreatitis, which eventually turn to chronic. So this is something new and interesting that we are looking at. And more the number of genetic polymorphisms, the higher the risk of recurrent acute, and that progresses to chronic. So maybe in the next 6-8 months, we'll be seeing that paper.
Do we have any longitudinal studies by which have shown that by giving antioxidants, we are able to prevent the further progression of recurrent acute pancreatitis to chronic pancreatitis?
That's a wonderful question. We have several patients on antioxidants with recurrent acute pancreatitis. So we have not done a designed a very systematic study as yet, but from clinical experience, what we see, and maybe you might have experienced this, especially the antioxidants containing methionine, a high dose of methionine, if the patients are taking, we give it for 3 to 6 months. During that period, they do very well, but once they stop the antioxidant, they will come back with a bout of pain. It may be documented acute pancreatitis or some minor elevation of lipase, but still pancreatic pain. So probably if longer study for several years, we think we might be able to slow down the disease. I don't say we'll be able to revert the disease or make the pancreas normal, because most of these are genetically driven and we cannot change the genes, but at least we might think of reducing the progression of the disease or slowing the severity. But that we need to do a properly designed longitudinal study. But clinical experience, yes, so we do think that way.
Professor Kapoor, we don't have any questions in the chat.
Can we have some comments from Dr. Puneet, Dr. Ramesh, and Yogesh? Because Yogesh has worked all along in Germany. So,
my question, thank you. My question is, since you have also a large database, have you looked for the role of smoking? Because it has become very evident from data from the US, also the SPINK mutation, especially the laboratory it is coming from. I had the honor to invite this person to our center in Hamburg. It seems that smoking is the predominant leading factor.
Exactly,
and if you have in your database this data collected, that you can isolate a subgroup, non-smoker or smoker without alcohol intake and negative for the mutations, and look into how is their disease progression and response to therapy, whatever type of they have got. I am pretty sure that you will find some interesting data to report on.
Agree. Sure, we have done that. We are seeing that patients who are smokers have a faster progression compared to, or alcohol plus smoking has a faster progression compared to alcohol alone. And these patients do not respond to any kind of antioxidant therapy somehow. We have shown in different studies also where we could show that by doing early intervention, we may be able to delay the onset of diabetes. That was a 6-year follow-up study with 506 patients, published, I think, 2-3 years back. So in that cohort of patients also, the patients who had alcohol and or smoking, they did not respond well. In their case, the diabetes did not change, but only in the idiopathic it works. So smoking definitely has something additional to do on top of the usual pathophysiologic events. And in fact, you have rightly said, smoking is much more important risk factor than alcohol. Alcohol is probably just a little trigger on the genetic background, but smoking by itself cause lots of havoc in the acinar cell.
Quick comment from Puneet and then concluding remarks by Dr. Varghese.
Yeah, one of the questions I've always had is the doctor and the patient both changing their socioeconomic background? The Dr. Balakrishna's second study, which included a lot of centers, Varghese, I think, had contributed the second or the third largest center from. So I think the proportion of patients from the private sector was much higher. So, in the 80s and 80s and early 90s, it was most of the good gastroenterologists were in the public sector only. AIGs and all were not there anywhere.
Yeah.
I don't know whether we are. So when I moved to Cochin, I thought I'm going to see patients of CCP every day, but it was just the same incidence as Delhi. So I don't know whether it was because it was and this was a mixed charitable So I'm just wondering what your thoughts are on that.
So we see patients from all over India, except from Kerala. We don't see, actually. It goes to all of you, Dr. Ramesh, yourself. But we do see lots of patients from Telangana, Andhra, eastern part of India, northeast, even western. So and most of these patients are like not the very well-to-do, especially from the eastern part. I mean, they're middle class patients, and they show the same disease behavior when we compare with the well-to-do and the higher class patients also. So I think the disease behavior is same across the socioeconomic status, and
And just to answer the previous question, I think in the list of that 1,086 patients multi-center study, smoking was there. I think in less than 30%, which I also found surprising.
Yeah.
But I think it's a very important factor for maintenance. Those who get off alcohol and don't stop smoking, the pattern of pain, I think, does continue unless they stop smoking as well. So I think it's definitely a core factor. Yeah.
Right. And it's a different type of pain. They involve more of the nerves. So we are doing several studies on neuropathy, pancreatic neuropathy, and we do see they have a different kind of pain pattern, like the pain perception is different, and it's very difficult to stop smoking. Patients will easily quit alcohol, but like after all attempts, they can't stop smoking. So that adds to the problem.
Okay, I think we need to. So, Dr. Varghese, any last minute?
Yeah, there is no doubt that the pattern of chronic pancreatitis has changed. It's not only compared to the West, but in our country itself, it has evolved. It has evolved from the disease of the younger population to disease of the middle age, less diabetes, easy control of diabetes, less complications, and perhaps less surgery. Okay, so the disease is changing, and we are detecting very early cases also. So I think we have to do a lot of research. And one thing is perhaps common, that the disease is more common in the coastal belt, where perhaps the rice eating is more, and one has to look at the eating of carbohydrate, the microbiome, where the fermentation, whether it produces some funny ethanol-like substances, etc., will have to be studied. So it was a wonderful talk, Dr. Talukdar, and I thank you for that talk, and I also thank Dr. Kapoor for inviting me. Over to you.
Thank you, Dr. Thomas. Thank you, Dr. Talukdar. And now we move on to the next session, which is how to investigate a pancreatic head mass, which is a very frequent clinical dilemma. And to deal with this, I have my former colleague from SCBGI, Dr. Sadiq Sikora, who's currently at Sakra Hospital in Bangalore. He is the current president of the Indian Association of Surgical Gastroenterology. And to chair the session, I have one of my former fellows, again from SCPGI, Dr. Arun, who's currently at the Sri Gokulam Medical College in Trivandrum. Arun, please start.
Thank you so much, sir, for the wonderful session so far. And thanks for making me a part of this. It is with great pleasure and happiness that I am able to invite my own teacher, Dr. Sadiq.
Arun, your connection seems to be weak.
Chronic pancreatitis. Over to you, sir.
Okay, Sadiq, please start.
Thank you. Good evening. Yeah, good evening and good afternoon to everyone, various parts of the world, and thank you, Dr. Kapoor, for inviting me once again on this wonderful forum. So, as you said, we are now coming to the clinical aspect of chronic pancreatitis, which is, and one of the vexing things is when there is a head mass in chronic pancreatitis, whether it is inflammatory, various other diseases versus cancer. So if you look at almost about 30 to 50% of patients with chronic pancreatitis may have an inflammatory head mass. And a proportion of these may be malignant or may masquerade as malignancy, and you may not be able to get the definitive diagnosis unless you do a resection and final histopathology of this. We also know that chronic pancreatitis is a pre-malignant condition, and the risk of cancer is 15 times higher. Majority of the time, the cancer is located in the head, and therefore, again, the head mass presumes great importance in that. Now, if you look at the incidence of cancer in chronic pancreatitis, this first study is from Stanley in Chennai, and they saw, of course, a selected group of patients, almost 1/3 had a malignant head mass. Now, there's a study from Europe, that is Germany and Austria, and there, when they did looked at all the resections over a period of time, they found that 7% had malignancy. And again, from Germany, another study showed 1/3 of patients had malignancy. So there is a wide variation in the incidence of malignancy in chronic pancreatitis. So when you have a mass in chronic pancreatitis, the most important issue which we want to look at and find out is there any cancer in that? And of course, the mass could be those patients with calcification and without calcification, and that puts another sort of issue which we need to contend with while investigating this and looking at possibilities. So the other possibilities which are common in this scenario where there is a head mass is a focal autoimmune pancreatitis, paraduodenal pancreatitis, or the classic mass-forming chronic pancreatitis. And the challenge to the clinician is to differentiate this, because each one has a different course, different treatment, and therefore it is important to get a diagnosis. Important to remember that clinical indicators are critical in determining the type of head mass in chronic pancreatitis. So age is important. Elderly people more likely to have cancer. We just discussed about alcohol consumption, which is more in the West, and this alcoholic pancreatitis with head mass poses different challenges. If you have an extraglandular involvement like salivary gland or IBD history, then it assumes significance for consideration of autoimmune, focal autoimmune pancreatitis. But more importantly, pain, which is a common symptom of pancreatitis, but when it reappears once there is relief, or it changes in character, intensity, duration, then it is a red flag sign. Unexplained weight loss, despite enzyme supplementation, new onset diabetes or worsening of diabetes, and then certain complications like jaundice, history of gastric outlet obstruction. So if there are any of these, then you need to look at the patient with a bit of suspicion and go all out to figure out what is is there an element of cancer in these patients. So again, just for these things, the laboratory values are important to look at diabetes control, liver function tests in case of any obstruction, and of course the tumor marker CA19-9. But the workhorse of all these investigations, despite having done ultrasound and other investigations, the main workhorse remains the cross-sectional imaging, which is CECT with pancreatic protocol or an MRI along with an MRCP. And we'll discuss other modalities which would contribute to arriving at a diagnosis in a head mass. So if you look at these pictures, you can see that there is a head mass here with calcification. And then you see a kind of hypo-enhancing mass in this area, which raises suspicion of malignancy. In contrast, you have calcification, a mass with infiltration into the vessel, which becomes rather obvious that you are dealing with malignancy in this situation. Another case with lot of calcification, but you see a mass in this area with involvement or close to the vessel, a likelihood of malignancy increases. But that's not the obvious scenario in most patients. So this is one way you would be able to differentiate on CT scan between mass-forming pancreatitis and ductal carcinoma. So important things to observe is how the duct is, whether there are associated changes in the duct in terms of chronic pancreatitis, how the calcification is, and the vascular encasement. So if you look at duct penetrating sign, which is very important sign, that is indicating that the duct can be seen through the mass, but there is no obstruction. And if there is other collateral duct changes in terms of side branch dilatation, calcification, then most likelihood this is a mass-forming chronic pancreatitis in contrast to a ductal adenocarcinoma. But if you have calcification which has been displaced due to the growth of or evolution of a mass, if you see a double duct sign wherein both the ducts, biliary and pancreatic, is obstructed, vessel encasement, and then duct to parenchyma ratio wherein there is atrophy of the gland and dilated duct, usually in malignancy, then these are indicators that in this chronic pancreatitis, there is perhaps malignancy. So these are signs which are quite specific for pancreatitis and may have high degree of sensitivity. The other imaging is MRI. Unfortunately, on MRI, when you look at these lesions, most of these lesions, which I mentioned, all four of them, have similar characteristics. They are T1 iso or hypointense, T2 iso or maybe hyperintense, as you can see in this in T2 hyperintense lesion. But the other associated abnormalities are important, like biliary obstruction. And on contrast, this lesion is usually hypoenhancing if you give gadolinium contrast. So this is the typical representation on an MRI. You can see the duct through the mass, and this is the duct penetration sign, which is typical of a benign pathology, which could be any of the benign ones which I talked about. Whereas when you have the obstruction and cutoff of the duct, then it is more likely to be malignancy. If you have biliary obstruction, then MRCP is important. And as you can see by this classification, the last three types, 4B, C, and 5, are more indicative of malignancy. And these are the pictures. There's a duct cutoff or a double duct sign, which indicate. Now, if you look at the other inflammatory masses which you encounter, which is a focal autoimmune pancreatitis, which is the type 2 variety, wherein only head mass is there. Now, this is the idiopathic duct-centric type. Unfortunately, IgG4 is not raised in this. There is rarely extraglandular involvement, but in 1/3 of cases, you may see inflammatory bowel disease. The characteristic finding is the capsule-like rim halo sign on contrast on cross-sectional imaging. So in this, as you can see, that there is a halo sign around the mass which is present there, and this has very high specificity. If you have multiple skip strictures on bile duct or in pancreatic duct, then it also is a situation where you may suspect that it could be a focal autoimmune pancreatitis. The other entity which now we are recognizing and seeing more and more is the paraduodenal pancreatitis or groove pancreatitis. And now you can see here, this is the duodenum, this is the vessel, mass, and you see this hypoenhancing area in the groove, paraduodenal groove. So you have a widening and thickening of the paraduodenal groove. You may have calcification suggestive of chronic pancreatitis. And this is the MR sequences, hypo or iso-intense on T1. And on T2 imaging, you can see the cystic or microcysts which shine up on T2 imaging. And similarly on MRCP, duct displacement with microcysts. And these are characteristic features of paraduodenal or groove pancreatitis. So if you have a mass with absent calcification and focal mass, and if you have duct penetrating sign, loss of lobulations, and hypodense fibrotic rim surrounding the mass, then it is an autoimmune pancreatitis. Whereas if there is encasement of vessel, extrapancreatic invasion, duct dilatation, most likely it is malignancy. Now, this is one thing which we keep on discussing, that what is the role of PET-CT in differentiating between inflammatory mass and a malignancy. Now, not much data is available. A lot of studies are there, but they are inconclusive in terms of PET-CT in itself being diagnostic for malignancy. But now there is data coming out, dual point PET-CT, that is early imaging and late imaging. And this is from All India Institute again, which shows that for smaller lesions, dual time point PET-CT is better with sensitivity comparable to a EUS FNAC. So it could be helpful in some scenarios, especially if there is metastatic disease, you may be able to differentiate that. The other modality which has come in vogue in use of a focal mass is endoscopic ultrasound and biopsy. Now, when there is just a solid tumor, it has high sensitivity and ability to differentiate between malignant and benign once you take a biopsy. But the sensitivity goes down much when there is associated chronic pancreatitis, especially the calcific variety, and the sensitivity goes down even up to 50%. Also, in reference to FNA and FNB, if you do a good chunk biopsy, then the likelihood of getting a diagnosis is much higher. So if possible, always do a EUS biopsy in these scenarios. So this is one example that you have a mass on CT, EUS shows that mass, and biopsy shows that it is adenocarcinoma. Furthermore, you can enhance the diagnosis in these lesions by doing molecular diagnosis. And some of these genes like KRAS gene mutation, P16 allelic loss, and DPC4 gene mutation, if you sort of identify, even on an FNA specimen, the sensitivity increases to 100%. In contrast, if there is absence of KRAS mutation in the tissue, then it strongly suggests that you're dealing with a benign pathology. So this addition of this can enhance in difficult situations. There are other modalities like contrast enhanced ultrasound and EUS elastography, which is being evaluated, has not come into mainstream, and we don't sort of use this as, most often in our clinical practice, and therefore we don't have much experience on that. The other thing is about artificial intelligence in pancreatic head mass. And I think this is going to be a game changer in diagnosing head mass. And one of these studies which has been published, especially looking at EUS, because EUS is so operator dependent, and to sort of read the images, there is a variability in the inter-observer reading. And therefore, this study, which looked at EUS with various AI instruments, comparing whether you can differentiate between adenocarcinoma and a chronic pancreatitis in variable number of patients, and you can see extremely high accuracy in determining malignancy. When you put together all the clinical and other factors together, so this is predictors of malignancy from Stanley Medical College, and they found that bilirubin, CA19-9 at a cutoff of 127, a dilated MPD of 11.5 centimeter cutoff, and a bile duct which is hugely dilated, have high sensitivity and specificity for diagnosis of malignancy in chronic pancreatitis. And similar has been shown by the Cochin Ramesh's group way back in 1992 and then 2009, saying that high bilirubin, short duration of symptoms, duct block, and CA19-9 more than 300 is indicative of malignancy in chronic pancreatitis.
Sadik, 3 more minutes, please.
Yeah. Oh, fine. That's okay. So similar to putting clinical and imaging features together, when you do multi-imaging evaluation, and this study looks at multimodality imaging of CECT, MRI, and PET, and they came out with certain characteristics which would indicate malignancy: a size more than 4 centimeter, Hounsfield unit of 21.8 in arterial phase compared to 37, that is delayed enhancement. And as we talked about dual point PET CT, so in the delayed phase, when the SU is more than or close to 5, and combined together these features, it is more likely to be malignant. So this is the kind of algorithm which you would have. There is a mass in a patient with features of chronic pancreatitis, high index of suspicion because of the clinical issues which I highlighted: jaundice, weight loss, change in character of pain. Then these need evaluation, cross-sectional imaging, biomarkers like CA19, endoscopic ultrasound, biopsy, and if it shows malignancy, then treat accordingly. If it is benign, administer treatment in the same manner. There will be 10% of patients where you may not arrive at a diagnosis despite all this, and there the clinical decision has to be taken to manage these patients. So the take-home messages from how to evaluate this is clinical context is very important. Cross-sectional imaging with CCT, MRI, MRCP is the cornerstone of evaluation. Endoscopic ultrasound and biopsy with molecular markers has the potential to enhance and reach the diagnosis in a large majority of patients. And I feel that AI-based diagnosis will potentially resolve the conundrum of head mass in pancreatitis. Thank you very much.
Arun.
Thank you, sir. Thank you, Sadiq sir, for the wonderful presentation on how to evaluate a pancreatic head mass. Lots of points, but beautifully covered in this very short time. And questions from the panel, please.
So can I start?
Sir, please.
Okay. Yeah. So Sadiq, if we have a mass in the head, we don't know whether it is inflammatory or malignant. Some investigations are favoring benign, some are favoring malignancy. Can we be 100% sure and tell the patient that, look, it is benign and it doesn't need resection?
So, as I showed, there are certain features which are characteristic. And if you find those, then you could be certain to a great extent. As I showed that if a combination of certain investigations, including PET with its characteristic features, only by imaging, you may be reasonably certain that you're dealing with malignancy. But EUS biopsy is most importantly required to have a definitive diagnosis preoperatively. And I think with the availability of this in this time and age, I think that should be the final sort of investigation which should tell you. And as I said that despite all this, at the end of it, you may still have about 10 to 12% of situations where the diagnosis is not certain. And therein, you will need to have a discussion with the patient whether resection is what you need to do or a drainage still and see what it turns up. One more aspect which I did not cover because it was preoperative evaluation is intraoperative evaluation, because you still have a chance to determine whether there is malignancy or not by various features and taking a biopsy at that time. So I think in this time and age, we should be able to make a diagnosis in a large proportion of them, but a small proportion, you still will have to take a clinical decision.
Puneet sir, please.
Yeah, I think this is one of the few areas where we must upfront before we investigate. Dr. Kapoor's question is extremely valid. We must first tell, we do all this whole plethora and then tell them, and then we turn out to be wrong is also a problem. So we must tell them upfront that we don't know. I think as doctors, we are very hesitant to do that. And this is one area where, I've burnt my fingers again and again and again with I've had young patients with all these, high CA19-9s included. And I told them, that it's very likely to be a malignancy. The guy says, I'll commit suicide. I've got such severe pain, you operate. So I went ahead with the logic that if it is malignancy, I'm not going to change his natural history. But if it's chronic pancreatitis, and I don't operate him and give him the chance of getting a pain relief. So we told him that we'll take biopsies, and it was not suitable for a Whipple. It had to be extended drainage kind of a situation with head coring. And of course, the frozen was negative, which is probably pointless because you need to take that decision up front. But he had absolutely no features of malignancy. He's been followed up for more than 12 years, with very good pain relief. Many other patients who've been operated multiple times, told it's an inoperable malignancy, come to us. Second surgery has shown it still to be a CP. So I think what we need to know is the clinical conundrum, is what are we going to change in this patient? So the two main places we need to intervene is severe pain, and where there's no pain at all and a doubt of malignancy. So, because the problem is if it's only CP, we don't need to intervene. So only when there's a high index of suspicion of malignancy and it's still operable. So this is, this dual equipoise has to be counterbalanced with the fact that most of the patients with both the diseases are probably inoperable for cure. So, putting all that into perspective, I think we should tell the patient up front, we don't know. We're going to look at it. And, even after this investigation, we may still not know. We have a reasonable idea that, it might be malignant, but it still could be benign. And I feel that hope gives the patient a lot of, optimism.
Yes, that's it, sir. Dr. Yogesh, please.
Yeah. So, Sadiq, of course, I remember you. I didn't forget about you. I see this whole thing a little bit different. I am very critical towards biopsies, because from pancreatic cancer scenario, we would not, if it is the disease is resectable, we tend nowadays not to do a biopsy. So in those cases where you cannot differentiate between CP or PC and the disease is upfront resectable, what change of management are you looking into not to go take this patient to the OR? You can address in such scenarios the chronic pancreatitis with excellent results with an Whipple procedure. Okay. Secondly, if the disease is not resectable, then in the oncological setting, you will have to prove that it is a cancer. In that scenario, the biopsy is mandatory. But in an upfront resectable case, patient with the symptoms, whether only pain or jaundice or whatever, I don't see the necessity for biopsy because it's not going to change the management from a surgeon's point of view. If you want to look into endoscopy versus surgery for chronic pancreatitis, this is different. But as we have heard yesterday and also from the literature, long-term outcome for chronic pancreatitis, surgery is still the best option that is for this patient is required.
So can I just respond? So, I mean, see, the thing is that in what you're saying holds true in many other scenarios, but chronic pancreatitis, I think, is a different entity altogether. The reason being that you have options of treatment beyond just resection. And it depends what is your threshold for going for resection. And I was last in a debate where I was debating in a head mass, drainage is good enough compared to a resection, of course, after you rule out malignancy. So considering that, there is an option. I know that in certain parts of Europe, resectional surgery is favored over drainage procedures, and there they might have a different outlook towards this. But when you have an option for drainage and when there is an equivocal kind of situation, I think endoscopic biopsy would not sort of tarnish the oncological issues or barriers, and you could still have one more attempt to establish a diagnosis before opting for either resection or drainage. And I don't agree when most people say, I mean, of course, it depends on what stage you find that, but that, like Puneet added both optimism and pessimism in the same statement when he said that malignancy is incurable, but we should give them hope. But I don't agree that it is always incurable. It depends on in what stage you get them. If you get them in an advanced stage, understandably it is incurable. But now with better imaging, I'm sure we are able to pick up more and more, at least lesions which are suspicious, and therefore opt at least for a resection in those. You have to remember that, as Rupjyoti showed, that incidence of cancer is much less in our scenario as opposed to probably the Western scenario. And therefore, in that situation, we don't see a lot of cancer which need to be resected in chronic pancreatitis. And therefore, we have an option of drainage in these patients. So a little bit of different philosophy, and therefore more attempts to make a diagnosis of malignancy in this.
There are two small questions on the chat. Role of intra-op core biopsy. Quick comment.
So, I mean, that is an option. Earlier, there were a lot of issues regarding that, but recently guidelines have come up in how to look at the frozen section in this, and it has improved the ability to diagnose. But targeting is a big problem. If you have intra-op ultrasound, you could target it. One of the things we know in this is a core biopsy is better than a wedge biopsy, and a good pathologist is important if you want to take a decision intraoperatively.
Pancreatoscopy.
For diagnosis in head mass, I don't know. There could be a certain situation where there is a double duct sign and you are looking at IPMN as opposed to a head mass causing a malignancy and double duct sign. And in that situation, pancreatoscopy may be helpful.
Arun, concluding remarks before we
just a small point regarding clinical findings to predict a chance of malignancy in pancreatic head mass. The Government Medical College Trivandrum group has proposed one more point, that is first presentation of chronic pancreatitis after the age of 50 years. And as Sikora sir has explained every aspect in a beautiful way, let me summarize by saying signs, symptoms are extremely important. Addition of biomarkers like CA19 will add to the values. Next would be a contrast enhanced CT. And in any suspicious cases, EUS graded FNA is going to be, FNA-B biopsy is going to be very helpful. And in still suspicious areas, we can do an additional imaging with an MRI. But let's wait for some more beautiful studies and maybe analysis by the AI series of investigations and artificial intelligence, those things. I think we will get much more answers with a clearer picture in the near future. Over to you, Kapoor sir. Thank you so much for the opportunity.
Thank you, Arun. Thank you, Sadiq. There are two comments from Dr. PuneetDhar for the sake of delegates. He says that frozen section can be very difficult in many situations, and biopsy has a poor negative predictive value. So with that, we move on to the third presentation, which is going to be by Dr. H. Ramesh from Lakeshore Hospital. And the chair for this session will be Dr. Sujoy Pal, who's a professor of GI surgery at AIIMS, New Delhi. Over to you, Sujoy.
Thank you, Dr. Kapoor. It's a pleasure to be part of this surgical festival. And it's my pleasant duty to call upon Dr. H. Ramesh from Lakeshore, Kochi, who is almost synonymous with the surgery for chronic pancreatitis in our country. And Dr. Ramesh will be talking to us about what is the association between chronic pancreatitis and pancreatic cancer, which is an important thing at the end of the day. Dr. Ramesh, please.
Thank you, Sujoy. Am I audible?
Yes.
Yeah. Thank you, Sujoy, for the kind introduction, and Vinay for the invitation. And congratulations to you on this really splendid initiative of educating all of us. I wanted to address this by asking myself 8 questions. First, is chronic pancreatitis pre-malignant? And from 1992, from our center, a year later from Chennai, and in 1993 from Albert Lowenfeld's International Pancreatitis Study Group, it became clear that the risk of cancer in chronic pancreatitis, regardless of etiology, was substantial. And in fact, this has been further emphasized by recent publications in the last 5 and 6 years, which showed a 8-fold increase in risk of pancreatic cancer. So let's start by saying that, yes, if you have a patient with chronic pancreatitis, we must remember that they may have cancer. India is a low incidence country for pancreatic cancer. And now that means we are now a high incidence in this group. We also understand that metaplasia and dysplasia are steps in the progression, and this demonstration of worlds of chronic pancreatitis and atrophic glands, cancer, and dysplasia in the same specimen came from Dr. Pushpa Mahadevan in our center some 30 years ago. The second question is, can we reliably distinguish inflammatory mass from cancer in chronic pancreatitis? Sadiq has already given us a very thorough insight into this, but all we can do is try, and we can use all of these methods, all of which have been emphasized. But I wanted to further say that one of the reasons why biopsy is negative is because the cellular yield of this pancreatic cancer lost within the worlds of chronic pancreatitis fibrosis is less. And so several passes are required. Rapid on-site mounting is mandatory, and a skilled pathologist is absolutely paramount. Again, because the imaging is not foolproof, that's why centers like Just One's and ours have to resort to many, complicated, seemingly regression equations to try and nail down the risk of cancer or in a particular mass. But why is it so important to distinguish inflammatory mass from cancer? And it is very important because if I would have a benign case, I would do a conservative operation like a fry. And if it's a malignant case, I would like to do a radical operation, which is a pancreatic duodenectomy. And the three possibilities that I see are that you may have a histologically proven cancer at the end of this preoperative algorithm. And then, of course, you can go ahead and do a pancreatic duodenectomy. The clinical radiological in-use findings of mass-forming pancreatitis are present. Then if it's clear, there's nothing to suggest malignancy, then you can do a Frey procedure or equivalent. And if it's indeterminate, you could do an intraoperative transduodenal TrueCut biopsy. That does work, Dr. Puneet. The TrueCut biopsy is fairly good yield, and you can proceed with the resection with a reasonable confidence of having done a cancer operation. So I would like to avoid Whipple resections for benign masses and a Frey procedure for cancer. Why not resect all the masses? If a mass is a cancer, and the decision to resect would have been vindicated, but the median survival is only 30 months. If the mass is a mass-forming pancreatitis, on the other hand, the patient would live longer, but as a pancreatic cripple with pancreatic functional deficiency and poor quality of life. In our country, we don't get outpatient pancreatic enzyme therapy support by insurance. And so it's a real problem to manage these patients. And I wanted to just mention this paper from Yogesh's parent unit in Hamburg, where the survival among patients who underwent pancreatic duodenectomy for chronic pancreatitis at 15 years was substantially lower than those who underwent a more conservative operation. So there has to be a keen desire among patients, among doctors, to try and nail down the benign cases and not do resections on all of them. Our own data showed that the pancreatic function worsened so much that only 47% had a good quality of life, whereas 3/4 in the cord group. So is there an imaging finding which could be pathognomonic? Actually, I have a very contrary view to what Sadiq said. Sadiq talked about hypo-enhancing area in an enhanced gland. I tend to think that there is an atrophic gland in chronic pancreatitis, and if there is enhancement within the atrophic gland, as you can see here, or if you can see this small enhancement here, this was actually seen in Puneet's old department and then advised surgery, but the patient went away to another hospital, that is to us, and then we resected this gland, and this was adenocarcinoma. As opposed to a homogeneous or heterogeneous equally enhancing gland, which is typical of chronic pancreatitis, I would tend to say that this is a very pathognomonic sign. Hypoenhancement can actually be because of inflammation, because of edema, and because of so many other reasons. I'd like to now summarize the data of our experience with cancers and chronic pancreatitis and summarize them in two groups, up to 2001 when there were 74 patients, and then up to 2017 where there were nearly double. And I'd like to list some of the myths that treatment is so ineffective. The philosophy was very nihilist in the beginning, that there was going to be no real benefit, but it changed to being more activist as we went along. A preoperative biopsy showed cancer in only a quarter of the patients in the first group and close to 50% in the second group. Even that was not good enough, and now we are much better than even that. In the remaining nearly 90%, we were able to nail down the diagnosis by an intraoperative biopsy. And post-operatively detecting cancer in the activist group happened only in 3%, 3 of cases, that is 2.3%. But remember that chronic pancreatitis is such a nasty piece of action that you can actually miss the cancer altogether and diagnose it a year later when they have metastatic disease. So when you did resection, and we used a slew of resections with additional organ resections, we found that 80% resectability in the second group, as opposed to quarter of the patients being resectable. And that was statistically significant. And the morbidity and mortality was similar. In fact, there was no mortality in the second group. The hospital stay was less in the second group. And the R0 resection increased dramatically from 50% to close to 80% in the second group. And that translated to survival in the second group, that survival after Whipple resection was 28 months median. Whereas in distal pancreatectomy, obviously, the results were much poorer, and survival after palliative procedures was really poor. So, and the really significant finding was R0 resection as a important factor in multivariate analysis. So, if you can do an R0 resection, and if you try, you can produce good results compared to even de novo pancreatic cancer. Question number 7: can we try and diminish the risk of cancer? We can and should do hereditary pancreatitis surveillance, but I would like to extend it to other types as well. And our current policy is to counsel patients to look for change in type of pain, worsening or development of diabetes mellitus, unexplained weight loss, and of course do laboratory tests like CA19-9 for whatever it is worth, and 6-monthly ultrasound. It may seem a little, this is a ethics committee approved prospective study, which I hope will show some positive results. Can you prevent cancer by earlier intervention? This is the paper which was discussed briefly by Adarsh and I think Vinay. This is the retrospective analysis, multi-center from Japan. I would like not to discount any Japanese data because it is so carefully collated. And the opinion yesterday was that it was probably not reliable. But please notice that only 50% of the patients underwent resection of the gland. The remaining 50 actually underwent drainage procedures. And yet, I'm sorry?
Cancers were higher in those where surgery was not performed.
And actually, you found that where the surgery was not performed, cancers were much higher than in those where surgery was performed. In addition to that, this ESCAPE randomized trial, the fact that there is definitely some likelihood of improvement in pancreatic function after either endoscopic or surgical drainage, and the fact that pain is such a debilitating symptom, which even leads to, in many of our patients, suicides due to pain, the cost of newer insulins, and the functional deficiency, and the large amount of pancreatic enzyme replacements, and the vicious cycle that it places them in. I might consider a gradual change from the policy of let patient earn intervention, which is the policy in many, many centers, and including ours, to I'm moving gradually towards offering intervention earlier in a symptomatic patient. Please remember, the fact is, the bottom line is that only 8 out of 2,200 operated patients who have been followed up 100% have shown up with cancer, and that's a significant achievement. So I would like to conclude by saying that chronic pancreatitis is certainly pre-malignant. Despite advances, we cannot yet make an accurate differentiation between inflammatory mass and cancerous mass. And really, when the doubt is extreme, one has no choice but to resect. But if you resect every one of them, you will leave patients with pancreatic, exocrine, and endocrine insufficiency, which is worse than death in many situations. If you are able to do the difference, it can really make a difference in strategy. If you see enhancement in an atrophic gland, please think cancer. R0 resection of chronic pancreatitis cancer improves survival. There is some indication that surveillance will help. At least our preliminary data suggests that, and cancer may be preventable by early intervention. And since I've finished well in time, I'd like just to say in response to some of the issues that was mentioned yesterday, that we have to treat patients based on symptoms. If they have no symptoms, they merit follow-up and medical management of diabetes or steatorrhea. If they have pain or complications, they need imaging to know what is going on. And we have to treat patients based on symptoms and not on the morphology. Regardless of whether they have duct dilatation, duct narrowing, whether they have mass lesions or no mass lesions, whether they have ductal disruption. It is not, that is just a guide to treatment, but it has to be based on the symptoms of the disease. And the third 3 millimeter duct is eminently drainable. And the numbers are increasing because I think 20 years ago, less than 5% of patients had undilated ducts. But now 15 to 20% of patients who present to our clinic have undilated ducts and they have intractable pain and they deserve treatment. Thank you very much for your attention.
Thank you. Sujoy.
Thank you, sir, for making this complex subject so clear and concise according to the stepwise questions that you have answered. I would, of course, open your talk for discussion to the House. I just wanted you to shed some light on the surgical problem which can happen in patients who have pancreatic mass, along with splenic vein thrombosis and collaterals around that area. Whether those are situations where you should be very clear upfront what exactly you are going to achieve before ending up doing a hazardous operation.
I think if I have a patient with portal hypertension in chronic pancreatitis, and if cancer is not on our diagnostic list, then the attention be turned to first obliterating esophageogastric varices so that you don't have a postoperative bleed, and then determining from the morphology of the gland what type of treatment would be suitable. Sometimes the amount of collaterals is such that, and the type of collaterals is such that, as Jacob Isbicki's unit showed, that a Fry procedure can be extremely hazardous and and may end up risking the life of the patient. In other situations, we've had and I'm really sorry that I didn't publish it, but we have had patients where we had chronic pancreatitis and we have a plethora of collaterals thanks to portal vein thrombosis. And when we ligated the gastrocolic trunk, when we put a ligature on the gastrocolic trunk, the portal pressure rose abruptly. And so we had to do the anastomosis in 2 sections, one in the head and one in the tail, the same jejunal loop, but we left the bridge of tissue with the duodenal artery and the gastrocolic trunk. This is just to say that you have to tailor treatment. Sometimes you may have to just stop with the lateral drainage, and that's about all you may be able to achieve. And that may or may not be adequate. But yesterday there was reference to doing a shunt and then to do a surgery for chronic pancreatitis. The most common shunt which in India we are familiar with and we are reasonably good at is the linear shunt. And that's simply out of the question in this situation. To do a makeshift shunt and then trust it to last for some time and then do a chronic pancreatitis surgery, it seems quite a difficult task. If the patient comes with acute pain, I would place a nasojejunal tube, allow the patient's inflammation to settle, CRP levels to come down to normal, and then cautiously operate this patient with one patient on that table. It's usually doable. It requires patience and care.
Thank you.
Sujoy, I'll take questions which the students have asked on the chat.
Yes, sir.
Yeah. So there is a question which maybe Dr. Ramesh can take, although it was addressed to probably Sadiq, that we have a malignant head mass and there are calculi in the duct with underlying chronic pancreatitis. So after resection, what do we do to the pancreatic duct?
It is our policy to always lay open the pancreatic body and tail and clear the calculi and to do a side-to-side pancreatojejunectomy instead of an end-to-side pancreatojejunectomy.
And is there any special surveillance strategy?
I have one more thing to say, that one of the critical issues there is that your jejunal loop, the vascular ligation must be done carefully because you need a much longer end of the jejunum to reach the tail. And if you have been careless, you may not be able to, in an obese or a patient fat-laden mesentery, to go back and revise your length of the end of the jejunum. So you must take care pre-operatively, or I mean intraoperatively. I don't think we have a surveillance strategy except to do ultrasounds and CA99s. Neither of it is effective, but for cost reasons, it is not justified. Clinical history, as Dr. Sadiq emphasized, is very critical. When patients are seen in a clinic, they have been seen by the same doctors. They analyze the symptoms, change in the body weight. If you have a change in the body weight, you have to see whether the patient's diabetes worsened. Why did the diabetes worsen? Because of poor care, or was it some other reason? So you immediately, your flag goes up to know whether you have a malignancy. But if the diabetes remains stable, a new pain has appeared, then think cancer, do a cross-sectional imaging like a CT scan, contrast-enhanced CT scan.
So I'll ask one of my question, and then Arun has raised a hand. So do you have data that if you operated on 100 patients with very inflammatory mass and did not do resection, in the follow-up, how many turned out to be malignant?
We have we looked at the data and published it in Indian Journal of Gastroenterology. We had 7 patients in that group. I think the only the corpus of the patients I can't remember exactly, but it was under 1,000. So it was not a large number because we are obsessed with cancer. We are doing so many tests before, and surveillance, as Puneet has mentioned, only helps the radiologist. It helps the clinician as well, if you like, Puneet, since you are so much into economics of healthcare. But when I am the patient, I want my pancreas looked at, and I have no problems, cost or no cost. I think every life is important, and I don't take a socialistic approach to healthcare. It's not acceptable. So it's about 7 patients is what we got. And after that, we've had an additional patient in whom, after the resection, even head resection produced foci of cancer, but that was probably a curable resection.
Arun?
That was a patient whom we plan to do resection in any case.
Sir, one comment and one question. Comment is to echo Ramesh point on contrast-enhanced CT. Suppose it's a very bad pancreas, as evidenced by it's a bag of fluid, pancreatic duct just border, and rest everything is replaced by fat. And if you see islands of so-called normal pancreas in otherwise non-CCP patients, that area should be viewed with caution. That area, we would say from the Trivandrum experience, that should be proved to be cancer unless proved otherwise. So even a normal appearing area in otherwise completely fatty replaced pancreas is a dangerous point to suspect cancer. Second question is, sir,
I would like to agree that it's not normal for patchy. It's not a Crohn's disease of the pancreas. You don't get a patchy kind of atrophy. If you get atrophy, it's pretty much at least a major section of the gland. So if you have islands of atrophy, I pretty much say that there must be something wrong there. Something is going on. Sir,
and my question is there any screening program to proactively find out development of cancer in chronic pancreatitis with long-term follow-ups? CA99 ultrasound.
Nothing has been published. We are accumulating the data. We haven't got our results yet. We haven't interim studied them, but we have only detected 8 in our post-operative group, and this has been applied to our post-operative group after surgery for chronic pancreatitis, and that's not probably the best way to study the disease. You had to study even the non-operated patients, and I don't see those patients on a regular basis, except those which came to my clinic.
Because in HCC, we have alpha-fetoprotein ultrasound like that, but anything for chronic pancreatitis?
Not yet.
Dr. Ramesh, there are 2 questions and comments in the chat. Maybe you can take them.
I'm sorry.
Yeah, limited head coring, as you said, and limited length of duct opening in case of collaterals around the pancreas. So will it be adequate drainage surgery? Somebody.
This is the extreme conundrum. And you have to, I always talk about doing the best operation in the first up. But if you don't succeed in doing that, then I guess you still want to win the battle, if not the war. Yeah. So you would have to say it is adequate drainage. Dr. Vinay, would you allow me to just present a set of 4 slides, a case capsule, which would be illustrative of this?
Yep, we have 7 minutes. So we'll leave 2-3 minutes for Sujoy to make some final concluding remarks. Yes, please.
Please go ahead.
I just like to have 1 minute. I can.
Sure.
Is there another question? It's in another presentation, so I'll need a minute.
Yeah, and the other question is, if at all you do a shunt, then interval between shunt and pancreatic resection surgery.
I have never done a shunt. In fact, Dr. PuneetDhar has suggested that we should actually do a makeshift shunt and do the pancreatitis drainage immediately. I think that's a thought, and I might want to do consider it. But I think I'm quite confident that with patients and industry, I can actually get there even without the addition of a shunt. Just give me a minute while I get that. This is very.
So in the meantime, you want to.
I think the question that the person wanted to know, what would be the gap if you're doing it for any surgery to reduce the portal pressure? Conventionally, you do wait for about 3 to 6 weeks.
Yeah, I've always been concerned about that, Puneet, because by the time you wait, you end up, having a shunt thrombosis.
Exactly.
You're pretty much back to square one, isn't it?
Exactly.
My feeling is that if you're actually tackling the kind of portal hypertension which develops with chronic pancreatitis, it's mostly left-sided or sinistral. So, I mean, one option is to do a splenectomy and a devasc if that is an issue. And that might lead to reduction in the pressure in the collaterals. Well, I think in
1/3 they do have portal vein thrombosis as well, and those are probably the it's not just somebody's written in that limited frame.
Those are the problems where you obviously a shunt. I don't think will be of help.
But any one of you, have you had to abandon a proposed pancreatic surgery because of extensive collaterals because of portal hypertension?
Yes, sir.
Yes.
I've had that as well.
Acute inflammation.
I can also join the.
This is what I want to tell the young colleagues in the audience, that if you find extensive collaterals rather than bleeding the patient to death, it is a wiser judgment to retract and try some other modality of treatment.
There's one question.
This is as a surgeon from also coming from I can say despite the early results.
You are not clearly audible. Please speak.
Now is it better?
Yes.
Is it better?
Yeah, go ahead.
Okay. I mean, we have published from Hamburg, as Ramesh also quoted, on chronic pancreatitis and portal hypertension. I think 2 or 3 papers in total. But after 20 years of experience in the center, I must say that nowadays I would look at the scenario a little bit different. And this is maybe a true field where we should retract and leave the treatment to the gastroenterologist or medical doctor. Because this is severe morbidity we are talking about, especially when we are aiming for preserving operations and not resectional. If you have an isolated superior mesenteric vein or portal vein occlusion, fibrotic occlusion, where you still have the option to reconstruct the portal flow either with the interposition or a graft prothesis, then you may consider to do a risky operation with still high morbidity and reconstruct the portal vein. But everything else with in combination of shunt procedures and organ preserving, I personally would not propagate this.
Yeah, but we have some substantial experience, Yogesh, with chronic pancreatitis and portal hypertension, and it's quite quite extreme portal hypertension, if you like, and the results haven't been as bad as you might imagine. So there is the one extreme that you may have to back off from the case, as Vinay said. But I just want to take you through this one case of a 37-year-old housewife.
Ramesh, there's a couple of questions in the YouTube channel. One is it necessary? I think they're fairly quick, so you can just quickly run through them. Is it necessary to continue PERT after resection procedures?
Absolutely.
Second is pancreatic head malignancy with CCP. If it's borderline resectable, role of NACT.
Well, if it's borderline, I don't think it'll be borderline resectable, it'll be unresectable probably, because it is so difficult to diagnose. And I just want to touch upon what Dr. Sadiq said, that we have found that in many patients, infiltration of the vessels does not necessarily mean even malignancy, because extreme inflammation can actually mimic teardrop effect as well as even encasement. And then finally, the histology is benign. So I don't know how to answer this question. I don't know how to the 100% diagnose cancer in the first place. So I can't talk about borderline resectable pancreatic cancer.
Yeah, true infiltration in malignant cases, you have where you have at the cross-sectional even more than 100 degrees of encasement. True infiltration is proven pathological only in less than 1/3 of the cases. The rest is just inflammation, desmoplastic reaction. This is from what our case studies in Hamburg have shown.
Yep.
So not everything we see as encasement is tumor.
So Puneet, is it okay to go on with this for 2 minutes?
Quickly, very quickly, please.
Yeah. So 2007, limited head coring was done because the surgeon did not feel that it was necessary to do more. Again, a lesson in retrospect. In 2010, the pain came back, and this was the cross-sectional image at that time. You could see a residual head mass with enhancement, and there were extensive calculi as well. She soon presented again with a huge cystic lesion like this. And we had no clue what this was initially. After figuring it out, we realized it's a jejunal loop, which is actually obstructed. And you can see that this is a descending jejunal loop which had been caught in this inflammatory process. And we could have sworn that this is malignancy. Several shave biopsies, true cut biopsies were done. And when we aspirated the cyst, we had actually, this was a cystic, if you like, a jejunocele because of the pancreatic fluid. And then we just did a side-to-side anastomosis to another roux-wide segment of jejunum. The pain disappeared temporarily, but later on the patient presented with biliary obstruction, which is quite logical because the patient had such extensive disease. Plastic stent, reoperation, frozen upper abdomen, and these are surgeons with extensive experience in pancreatic surgery. Several biopsies, percutaneous, EUS, open, all negative, metallic stent, tissue ingrowth into metallic stent, as you can see here, and then plastic stents inside metallic stents. So if you have a benign disease where you place a metallic stent, then you really have trouble. And in July 2013, she went off to the Gulf because she wanted to join her family. And there she kept neglecting her disease. We kept telling her that probably she requires a reoperation and probably a Whipple or probably something definitive, even though it's going to be technically difficult. But then she presented with septic cholangitis. She was airlifted from the Gulf and died despite aggressive intensive care. Post-mortem, we took the permission of the family to do multiple biopsies from the pancreas, no malignancy. So much for our erudition as far as what we can do. The moral of the story, I feel, is that we should try and do an adequate operation the first time, even in portal hypertension, if we can.
Okay.
Thank you, sir.
Sujoy, any concluding remarks, please?
Very quickly, I would just briefly run through what has been said. Basically, the fact is that chronic pancreatitis is a risk factor for malignancy, maybe to a lesser extent in our country than the Western world. And there are not many foolproof methods available for us to screen people so as to avoid malignancy. But as Dr. Ramesh has repeatedly pointed out, that the first attempt to approach these patients has to be done on the background of a properly evaluated clinical history and having done the investigations properly. And the first approach has to be the best approach so that the patient in the long term doesn't keep suffering from the thing. The other thing which came out was that resection not necessarily is associated with good results in the long term. They can lead to a decreased quality of life, and some studies have shown that the mortality increases at the long term. And so portal hypertension with chronic pancreatitis is a difficult problem where we don't have many answers, but a lot of questions. But even then, there are instances where you can get away with a lesser procedure without causing catastrophic bleeding. With that, I will hand over to Dr. Kapoor
Thank you, Dr. Ramesh. Thank you, Sujoy. And now we move on to the last, which this time, instead of keeping a lecture, we've kept an open house session, because in the previous two master classes, there were several questions or several aspects which we could not cover. So for this, I have a panel. All the faculty members who are present, obviously, will continue to be there. And I have Ajay Sharma, who's my colleague. He's the Chief of Surgical Gastroenterology at the Mahatma Gandhi Medical College Hospital. All the faculty, please come in, put your camera on. Dr. Deepak Mital, who's my and Sadiq's colleague from All India Institute of Medical Sciences way back in 80s, and who's currently a transplant surgeon in Chicago in US. And he has special interest in islet, so I requested him to join. We have Dr. Jayanti Venkataraman from Chennai, and I also have my colleague from palliative medicine department in my hospital, Dr. NipunLamba, and of course Yogesh has been participating. So what we will do, that since Deepak is abroad, he may have it's daytime for him, he may have commitments, so I'll request him to cover his topic first. So he'll tell us a little bit about total pancreatectomy and islet autotransplantation in about 5 minutes or so. Deepak, please.
Thank you, Dr. Kapoor, and the organizers and moderators and the people who are attending late at night. So with full disclosure, I'll tell you, I am a pancreas transplant surgeon. I don't do pancreatic surgery at this time. I did that way back in the past with Dr. Nandi and Dr. Kapoor. So I was asked to talk about islet autotransplantation and total pancreatectomy by Dr. Kapoor. So this is indicated in a very small subset of patients with benign disease who have either small duct chronic pancreatitis or idiopathic or genetically related acute pancreatitis, or hereditary chronic pancreatitis with a cancer risk. Also, if there's failure of conventional surgery for chronic pancreatitis, or if somebody has extensive trauma or benign pancreatic pathology. So you have to be very selective, because once you do a total pancreatectomy, these people have very severe exocrine and endocrine failure, which is very hard to control, even with islet autotransplantation. But for patients who are candidates for this procedure, it is a very good option. Now, when should you not do this? You should not do it in patients who have pre-existing type 1 diabetes requiring a lot of insulin, or steatohepatitis, if they already have portal vein thrombosis or portal hypertension, because you inject the islets in the portal vein, if they already have portal vein thrombosis or portal hypertension, then it's not a good idea. If they had a previous lateral pancreatic jejunostomy, obviously you'll not take the pancreas out. Or if they have psychological issues where the pain is, narcotic dependent, and they, even despite the pancreatectomy for pain, they're not going to do well. So once you do a pancreatectomy, a total pancreatectomy for chronic pain or the other indications I talked about, it has to be done in 2 stages. First, you do a distal pancreatectomy, resect the body and tail of the pancreas. And second, you do a pancreatic duodenectomy with the head and uncinate process. And usually it's done open, but you can do a robotic assisted, robotic approach now with, advances in robotic surgery. So to minimize ischemia to the islet tissue, you preserve the gastroduodenal artery and the splenic artery till just prior to the resection. So you can preserve the spleen with the short gastric vessels, and occasionally with the splenic artery and vein, but very rarely. So as soon as the pancreas is removed after devascularization, it is placed in cold preservative solution. You cannulate the pancreatic duct and inject collagenase and preserve the solution. The idea is to separate the exocrine portion of the pancreas from the islets. The islets, unfortunately, undergo some ischemic issues here, lack of nutrition, and end up with starting some apoptosis. That being said, after the collagenase separation, you end up with a small pellet, which can be infused into the portal vein. Now, this can be done at the same time as the original surgery for chronic pancreatitis. You can inject the islets in the portal vein. If you see a rise in portal pressure, then you can stop the infusion and inject the islets into the submucosa of the bowel or the omentum. Now, this has been proved to work in animals, but uncertain if it works in the clinical human model. After you do this, 1/3 of patients will get insulin independence or a positive C-peptide where the diabetes is less brittle. So it's definitely useful. In children, you have a higher rate of success. If they need total pancreatectomy, the success rate can be up to 50%. The longest period of insulin independence seen so far with this procedure is 12 years to 15 years. Again, I'll emphasize this for a very selected group of patients. So I'll stop there and answer questions.
So why is it that this procedure hasn't become popular? Is it because of the poor results, or is it because of the poor or because of the complications?
So essentially, first of all, you need to have a lab to process the islets, and not every center has approved lab where you can do this processing. Now, most of the centers like Minnesota or Cincinnati or University of Chicago, they already do islet transplantation for diabetes. For patients who have type 1 diabetes who are not candidates for a solid organ pancreas transplantation, they may do well with islet cell transplantation from 1, 2, or 3 donors, and they get insulin independence. So you have to have a center, a large center where you are able to process the islets. Then the islets undergo trauma. When you do the total pancreatectomy, this pancreas is already diseased and fibrotic, and in separating the islets from the exocrine tissue, they undergo more trauma, ischemia, and then when you inject them in the portal vein, they're obviously devascularized for 2 to 3 weeks, at which point revascularization happens. Until that period, you have to maintain a very tight glucose level with giving intravenous insulin on an insulin pump initially, because otherwise there's hyperglycemia, the islets get damaged even more. So it's, first of all, the availability of a lab to process the islets, and then the success rate depends on engraftment of the islets.
2 quick comments from Yogesh and Sadik, and then we move on to the next. Yeah, Yogesh.
Yeah, Deepak, I have been listening to many talks at the Pancreas Club meeting regarding this islet transplantation in chronic pancreatitis. And to be honest, outside of those centers, nobody understands what type of patients are treated, because the patients treated there have no morphological correlation what otherwise we address as chronic pancreatitis. So, I mean, is it some different disease, or is it a treatment option for a very early stage? Also, the long-term results with the islet transplantations are not truly convincing, because many of them become diabetic over the period of time.
Absolutely. I agree with you. That's why this procedure of total pancreatectomy for benign disease for chronic pancreatitis has to be very carefully selected. You have to tell the patient their expectations should be such that they will require a lot of pancreatic enzyme with every meal. The diabetes may not be cured permanently. So I quite agree with you that this has really not taken off. Like if you do islet cell transplantation for diabetes in patients who have kidney failure. They get a kidney transplant, they get islet transplant, the results are much better now. So I agree with you that, in chronic pancreatitis, you cannot do it for every patient with benign disease. And the results are not the best, but in a third of patients, it's great. You have insulin independence or less brittle diabetes, which can be managed. Because, if you do a total pancreatectomy, there is brittle diabetes, hemoglobin A1C is way above 9, and they get exocrine insufficiency.
Sadiq, quick.
Hi, Deepak. I just want to know that, is there a way to determine, because the results will depend on the islet yield, the quality of the islet, and the ability to sort of dissolve or digest the pancreas and get the islets. So is there a way to assess this before the surgery to know that this patient or this pancreas will have a good yield and good islets?
Well, that's a great question, but that's like predicting the weather 3 months from now. It's all, could be cloudy with a chance of meatballs. No, there isn't. The short answer to your question is no, there isn't. But if somebody is needing a chronic, total pancreatectomy for chronic pancreatitis, then you do it. You tell the patient to have expectation of about a 1/3 success rate for the, cure diabetes. But if it happens, usually it's durable. If the islets engraft, and you're right, it depends on the total islet yield and the purity of the islets and the number of islets. So, good point.
I know Rupjyoti and Ramesh want to say something, but I think we need to move because there are 2 other people. So if Deepak is staying, we'll come back to you.
Sure.
Yeah.
Sure.
So I think next I would request Dr. Jayanti to make a presentation on autoimmune pancreatitis, because that was not covered in the main program. And I thought that is an important topic.
Can I share my slides, sir?
Please.
It's coming as disabled participant sharing. Please allow me to share the slide.
No, we don't see it as yet.
I put her in spotlight. Does that help? Just try again.
Can you see my slides?
No.
While
the slides are coming up, Rupjyoti, you want to say something quickly?
So in this discussion, actually, islet transplant in chronic pancreatitis is mainly done because of pain. So that total pancreatectomy, the pain goes off. That's the basic concept. And University of Minnesota has a very low threshold actually for this, and they would do even for a normal duct disease or small duct disease. But the problem here is we are forgetting the pain. Of course, islet technology has developed. We do islet transplant for patients who require distal pancreatectomy, not for primary pain relief, but for giving back their islets. So it has been seen even after total pancreatectomy, 40% still continue to have pain. So that's a concern. On one hand, 1/3 patients only are insulin free. And on the other hand, 40% continue to have pain. So I think in chronic pancreatitis, we should still be very careful to use islet transplant as an indication. And many of these patients already undergo some kind of ductal intervention that reduces the islet and increases the risk of contamination. So I think that's what I would be very reserved to use islet transplants and a total pancreatectomy. So that's what I wanted to say. Yeah.
Dr. Jayanti, please.
Slides, sir?
Yes, we can see. Please.
Thank you, sir. And thank you, sir, for this kind invite. In the next few minutes, I'll give a brief glimpse of acute or autoimmune pancreatitis from surgeon's viewpoint. So why is this topic important? It is because many of the times following a surgical resection, we've seen that patients with suspected pancreatic carcinoma in fact have a benign pathology, and about 1/3 of them actually constitute an autoimmune pancreatitis. And recurrent pancreatitis has also been described in patients with autoimmune pancreatitis, and some of them even present as chronic pancreatitis with exocrine and endocrine insufficiency. And I think the most important issue is whether this particular autoimmune pancreatitis is actually a pre-malignant entity, and therefore they require long-term surveillance, or in patients who have a focal enlarged pancreas, how does one actually get through whether these patients do in fact have a pancreatic adenocarcinoma? So by definition, autoimmune pancreatitis is a benign, rare, distinct fibroinflammatory form of pancreatitis. And typically it's characterized by pancreatic pain in about 40%. Obstructive jaundice is the most common presentation in about 70 to 80%, with classical histological features of lymphoplasmatic infiltrate and fibrosis. And they have a dramatic response to steroids. So we have the type 1 and type 2, and what we see in our part of the world is we have the type 1 autoimmune pancreatitis, commonly seen in Asian countries, often in men in the 6th decade, and most of them have other organ involvement, and that is quite common in these patients. IgG4 is a common finding in our patients, and relapse is common even after treatment, unlike type 2, which is uncommon and not seen in our day-to-day practice. So in large surgical case series, although we talk so much about autoimmune pancreatitis, the overall prevalence is quite rare. It is about 0.7 to 2.4% amongst the various surgical cases that have been operated, thinking that they were patients with pancreatic malignancy, and many of them had other organ involvement, of which biliary was the most common other organ involvement. And in post-op resections, it was also seen that type 1 was the most common type of patients who had a resection. And in these patients, the IgG4 was quite common in type 1, and relapse rates were very high in these patients. And this was seen, and this is supposed to be what was seen in most of our patients from the Indian subcontinent as well. So these are some of the series. Up to 2022, type 1 seems to be still the most common type. Other organ involvement is not so common, and relapse rates are very high even after surgery. So we often have a problem of differentiating autoimmune pancreatitis from pancreatic carcinoma. And despite the fact that we have high-end imaging techniques like CT, MRI, MRCP, the sensitivity is quite low with most of these imaging modalities, but specificity is fairly high. And despite this, attempts have been made by several workers to distinguish the so-called mass-forming lesions in autoimmune pancreatitis from pancreatic adenocarcinoma. Amongst them, the duct penetrating sign and the collateral duct dilatation seems to be the most common, and distinctly absent is the double duct sign, the displacement of the calcification, the duct to parenchyma ratio, and the superior mesenteric artery to superior mesenteric vein ratio, that's more than 1. Most of the findings are more in favor of a pancreatic adenocarcinoma. So despite this, it is quite difficult in a given situation to distinguish between these two. Other findings are the vessel encasement or deformity, as Dr. Ramesh was saying, in chronic pancreatitis. Sometimes it's an inflammatory process that causes this changes in the arterial wall, and at times it may be mistaken for a pancreatic malignancy. With FDG PET, in most of these patients, autoimmune pancreatitis can have a diffuse or multifocal accumulation in pancreas, and that would help us to say that probably we are dealing with an autoimmune pancreatitis. So to summarize, a workup of autoimmune pancreatitis should involve a basic liver function test or liver biochemistry, and this is more important in patients who present with obstructive picture. Serum immunoglobulin, the IgG levels and IgG4 levels are absolutely important. This will help us to distinguish some of these patients. High-end imaging, which includes the CT and MRI scan, is absolutely necessary to distinguish the mass lesions in autoimmune pancreatitis from pancreatic adenocarcinoma. Of course, in some of the situations, one may have to resort to a histological diagnosis using the endo-ultrasound. So when we do get a patient and we find a mass lesion in the head of the pancreas, and we are in a dilemma as to whether we are dealing with pancreatic duct adenocarcinoma or we're dealing with an autoimmune pancreatitis with a mass, if we have a typical finding such as diffuse enlargement of the pancreas with a delayed parenchymal enhancement with or without capsule sign, along with any non-ductal imaging markers such as serum IgG4 or other organ involvement, I think we're justified in treating these patients with steroids. If, on the other hand, these patients have focal segmental enlargement of the pancreas, or there are other features such as low density mass, suggesting mass related to the head mass, then we have what is called as a collateral evidence. This is being discussed by Dr. Chari and others. And if the evidence is strong, and the collateral evidence is very strong, and if we have two of the three that is shown here, the PD stricture, the serum IgG4 more than 2, or histological confirmation of other organ involvement and radiological evidence of this thing, then these patients also be justified in treating with steroids. On the other hand, if it is modest and we have only one of the other three findings, then we are justified in taking doing an FNA with an endo ultrasound. If it is negative, then we can give a trial of steroids, wait for 2 weeks, reassess the patient, and then take a call whether we're dealing with a pancreatic head mass due to adenocarcinoma or an autoimmune pancreatitis. So the key message in autoimmune pancreatitis is it is very important to differentiate when there's a mass lesion to distinguish AIP from a pancreatic carcinoma. Always estimate a serum IgG4 level. One must have a good imaging, especially with the pancreatic protocol, with the CT, MRI, MRCP, and at times even ERCP. And there's a definite role for endo ultrasound, especially in indeterminate cases. And I think we're justified in treating some of these patients with steroids. Wait for 2 weeks and see whether when there is a mass and there's a huge doubt whether we're dealing with adenocarcinoma or not, and then reassess the patient to take a call whether we're dealing with autoimmune pancreatitis or a mass related to adenocarcinoma. I think in the present days, there are very minimal chances that we are likely to miss an autoimmune pancreatitis with a mass lesion due to a carcinoma head of pancreas, especially with the high-end preoperative diagnosis using the computed tomography, the MRI imaging, the endo ultrasound, and histology. And of course, this will definitely prevent us from doing unnecessary surgery in many of our patients. But despite that, recently we did have a patient at global hospitals where the patient did have jaundice, obstructive jaundice. He was a 70-year-old male, and lo and behold, at the end of it, after surgery, the post-op report did come as IgG4 related pancreatic head mass. Thank you, sir, for the kind invite and attention.
Thank you, Dr. Jayanti. Since we have to finish at 9, we want to keep to time, and I have Nipun with me. This topic I kept because it's a frequent question in the theory exam for the students. So I suppose if you write even half of what Dr. Jayanti has told, you will pass. So now I invite Dr. NipunLamba. We have a palliative care medicine department in our hospital, and I request him, although many of these aspects have already been covered in various talks, but he would like to summarize to us what is the pain management for chronic pancreatitis. Nipun, please.
Thank you very much, sir, for inviting me. I am Dr. NipunLamba, Associate Professor in Department of Pain and Palliative Medicine. I have done my fellowship in pain management as well as palliative care. So today we are talking about pain in chronic pancreatitis. First of all, I will be very short and precise. We follow WHO step ladder whenever we are dealing with any chronic pain. And pain in chronic pancreatitis is sometimes very severe. We start with usually NSAIDs, and then we move up the ladder along with adjuvants like gabapentin, pregabalin, and other NSAIDs. If the pain is relieved not from the step 1, then we move to step 2 of the WHO analgesic ladder, in which we are taking mild opioids like tramadol, etc., tapentadol even. And if it is not relieved, even by then we can switch to the step ladder 3. Step ladder 3 is having stronger opioids like morphine, fentanyl patches. These things are available to us, and they are freely available in our hospital also, Mahatma Gandhi. If pain is not even managed by them, then we resort to interventional pain management techniques. So after WHO step ladder 1, 2, and 3, we are going to interventional pain management. If pain is very severe, that we analyze that pain is not going to be relieved by WHO ladder, then we can shift to the interventional pain management even at the stage 1. But usually we follow the ladder and then we go to the IPM. So in interventional pain management, we are having many techniques for control of pain. We are having celiac plexus blocks, which is very useful. And apart from it, we are also having splanchnic nerve blocks. Block is a generalized term. Usually when we are using block, we mean we are using local anesthetic and depometrol. But what we are doing is we are neuralizing the ganglion. We are doing celiac plexus neurolysis, which is a very effective in managing chronic pain. And if pain is not even relieved by a celiac plexus block, and then we can resort to splanchnic nerve blocks. As we can know that there are greater, lesser, and least splanchnic nerves, T5 to T10, T10, T11, T11, and to T12. So we can block these splanchnic nerves. And also nowadays, there is an added advantage of radiofrequency ablation. These machines are available, these techniques are available. And what we can do is we can ablate these splanchnic nerves individually. And that can help us to relieve the pain. So the pain which is not even relieved by neurolysis, we can relieve by radiofrequency ablation of the splanchnic nerves. And apart from that, there are also when sometimes the pain becomes very severe and we have done the blocks and we are not able to control it. So in addition to it, we are having intravenous lignocaine infusions. Lignocaine is a local anesthetic, sodium channel blocker. So we are giving it in a dose of 2 to 5 milligram per kilogram. We are giving 3 to 4 settings. And it usually relieves the pain of, it helps in relieving the pain of chronic pancreatitis, intravenous lignocaine infusion and intravenous ketamine infusions also. Ketamine is an NMDA receptor blocker, and we are using it in combination with propofol and slight midazolam in very less amount, like 1 or 2 milligram. So intravenous ketamine and infusions are also very helpful in relieving the pain associated. So this is how we are managing our pain of pancreatitis as well as cancer pain. And we have performed in our institute various celiac plexus blocks as well as splanchnic nerve blocks. Yes, the results are sometimes dicey, but that's a part of practice, and we try to improve as we go on. But the success rate in these procedures is usually good. Patient gets good relief, and if we are able to manage the pain by medications after giving block, then we call it a success. We consider it a successful procedure. And thank you, sir.
Yeah. There is a question that what is the duration of action of these blocks?
Yes, sir. If we are doing neurolysis, we are expecting 4 to 6 months pain relief at least. And in CA pancreas patient, usually that's a good duration of pain relief. The duration of relief outlasts the longevity of the patient. And if we are doing radiofrequency ablation of splanchnic nerves, which we are now doing these days, so that lasts for about 2 years. And that is very useful technique as well as far as chronic pancreatitis is concerned, because in acute and chronic pancreatitis, they're reversible situations sometimes. But the CA pancreas is not reversible. So we don't neuralize in case of pancreatitis. We are doing radiofrequency ablation of splanchnic nerves, and it lasts for about 2 years. Local anesthetic and steroids are just for diagnostic purposes we are doing. We are not using as a treatment modality. We are either neuralizing or doing radiofrequency ablation.
Thank you. There is a comment which I have to read for the sake of the delegates given by Dr. PuneetDhar, that Dr. Sudeep Shah has suggested that we should look at globulin levels when we are thinking of AIP, because it is less expensive than IgG4. And if total globulin is less than 2, then it is unlikely, very unlikely that IgG4 will be high. So it could be a good screening investigation before asking for IgG4. So with that, exactly at 9:01, I would like to close this masterclass, and I would like to thank all the faculty and all the delegates who have joined. Today we had about 60 plus people watching it on the YouTube, and yesterday's session, Himanshi, Dr. Avinash's team informs me, has already had more than 800 or 900 views. So this is the information about Jaipur Surgical tutorial. Students who want to join JST, please send a WhatsApp message to Dr. Anand Nagar. And students who want to read a little more about chronic pancreatitis, send me a mail and write CP in the subject of the mail. And I would also like to acknowledge the technical support provided by one of my former fellows, Dr. Avinash Tank, who's currently working at Dwarika Hospital in Ahmedabad. So with that, we will, Dr. Ramesh wanted to say something about eyelid. So since Deepak is still there, Dr. Ramesh, please, 1 minute.
No, I think in the late 1990s and early 2000s, we had a pilot study on extracting islets from patients with Indian pancreatitis. We found that the extreme fibrosis that is associated with the pancreatitis in India, they just didn't centrifuge out, and we had trouble separating the islets. I wondered whether there was new technology that made all that absolutely, like falling off a horse. I wanted Deepak to comment on that.
Sure. you're absolutely right. If there is severe chronic pancreatitis with a lot of fibrosis, it can be difficult to separate the islets from the exocrine part of the pancreas. So, you can definitely try it. And if successful, whatever amount of islets you can get out of the pancreas helps. You inject it into the portal vein. And I think the patients have to be counseled before doing this, not to expect anything more than maybe 15-20% in these cases of insulin independence.
Thank you.
Yeah. So Avinash is there. Once again, thanks to Avinash and his team for the technical support, not only to the master classes, but to all the activities of the Jaipur Surgical tutorial. So with that, good night, goodbye, because we want to keep to the time, start at 7 and finish at 9. Thank you very much. Thank you all.
Thank you very much.
Great session. Good night, Vinay. Bye.
Bye.